Hey, everybody. I did not just get off of work and then immediately sit down in my chair and start recording this. Okay, I did, but we're all guilty here. You did the same thing too. Admit it. Thank you. So, I'm just here to present one of the cases I had here at Mayo Clinic right around month 2 when I just started here. This is going to be primarily a vestibular case, sort of a complex pathology pattern that I got to see. So, let's turn over to the details. Clinical case presentation by me. Just an overview of who I got to see. It was a 67-year-old male patient who came in with his wife, although his wife did not attend the case history or anything up until the results portion of the test. Appointment date and time, September 8th, 2023. I think I just said August. I'm stupid. 3 p.m., end of the day. So primary complaint, intermittent unsteadiness. He had a bit of a difficult time just sort of walking around and just getting from place to place. He was pretty slow on his feet. So him saying intermittent unsteadiness, it almost seemed more like it was persistent, but nonetheless, he did say he has some good days. So primary complaint was intermittent unsteadiness with a positional component. So it began 2 years ago, got worse roughly 1 year ago, and then his symptoms are triggered by turning his head, looking up and down, or leaning over. Now, let me let you know this. It was not BPPV. I know that sounds like it. He does not have any BPPV or like any positive Dix-Hallpike on this testing. So, his symptoms is causing a lot of difficulty walking. He uses walls for support. He wasn't using like a cane or a walker, but he was definitely in rough shape. All of his symptoms were exacerbated by being in a wide open space or not having a visual target. So if he was out in an open field with nothing in front of him, that was the worst for him. He preferred narrower hallways with walls he could lean on and with something to focus his vision on. He had 2 recent falls, one in February, one in August. The August fall happened when he was trying to transfer from a hardwood floor to carpet, and just that little bit of a lip caused him to topple over. The symptom frequency, he has basically 2 days on, 1 day off. Now, that's a bit of an oversimplification. It's not that measured. It's not that consistent. It's not perfectly 2 days on, 1 day off. It's more just like roughly 2/3 of the time he's not fine, 1/3 of the time he is. Now, because of the 2/3 of the time where he's not fine, he has stopped driving on the freeway because he never knows when his symptoms are going to be an issue. And again, if you're on the open road, you don't have too much of a visual target, that's going to exacerbate his symptoms. Now, case history. Long-standing history of cardiac dysfunction. He had multiple stents placed into his heart in December of 2022. His brother has beginning stages of Alzheimer's and Parkinson's, so he has a lot of concern, especially when you couple that with the fact that he was a college football player and had multiple concussions. He talked about how he was taught to lead with his head on tackles. You know, it was just that era where it was smash mouth breakneck football, and it was not designed for longevity. He has recurrent headaches. And then he has current breathing difficulties secondary to a throat infection that he had. And he got his hearing tested at an outside clinic where they discovered that he had an asymmetric hearing loss, worse on the left. And he was interested in pursuing hearing aids down the road. Now, let's get to the test battery, the VNG portion. We have the saccades here. So here's the tracing that I pulled from the DIFRA software. Now, not too bad, you know, on that right eye, you can see a little bit of an inaccuracy, but it's not that far out of norms. By and large, his ability to keep up with saccades was pretty good. So we didn't see anything there. What was of note was the smooth pursuit. You can see that as the actual frequency gets faster, his pursuit becomes increasingly saccadic, not psychotic, saccadic. So especially once he gets to the 0.7 hertz, I mean, it's really starting to be tough on him. And like this trace right here, this is pretty far out of phase. This, you have a double peak right here. I mean, his eyes are just having a tough time keeping up. Now, here is the kicker. This is the center gaze test. Look at his eyes. Realize that this is with no visual target. This is center gaze. He's not looking at anything. Nothing. But his eyes are doing this. You see those quick jitters? It's almost like his nerves are almost like short-circuiting. They don't know what to do, even though they have nothing to do. That is called microsaccades. So this patient had present microsaccades in every gaze test we did and throughout a lot of other tests that we did. So this was just something that we noticed, and there wasn't enough saccades for the computer to pick it up, but it was just something that we noted. Oftentimes people with cerebellar or central issues will have these microsaccadic intrusions throughout their testing. But when I caught that, I decided to take a recording of it because it looked suspicious to me. But yeah, present microsaccades. Now the calorics. As you can see, the data kind of sucks. I mean, and also one thing I need to say is the with fixation number and without fixation number, don't focus too hard on that. The with fixation numbers on this are high, but we have better tests of fixation coming up. We don't really try to clean up the with fixation data on the caloric screen because we have more sensitive tests of fixation ability down the road. That being said, who wants to clean this up? This will take forever. So just look at the without fixation numbers, 17.8, 14.4, bilateral monothermal calorics cold. And you could see on the Clausen plot there that it is within normal range on both sides. You're able to inhibit both sides equally. We felt pretty good just with the monothermal, so we decided to proceed with other testing, mainly VEMPs. So we did CVEMPs, and as you could see here, there's nothing to see here at all. These are pretty flat, no response, so that means his saccule is just not really giving us anything. We move on to V-hit. Transfer him to another room, strap him with a different set of goggles, and now I'm turning him left and right. So, what do we find? Right lateral, 0.84 with no covert or overt saccades, completely normal. Left lateral, 0.62, that is below normative range for amplitude. That was enough for an abnormal result, and we see this reduced V-hit amplitude just on the left. Now, I put him into the space chair. Sinusoidal harmonic acceleration. Overall, his gains, they're a bit on the low side, as you can see right here, but it's not terrible. The majority of the dots are within the normal range. Phase, I don't know what the heck was going on at 0.16, but the rest were okay. Asymmetry, again, something weird going on at 0.02, but again, the rest okay. We decided to call this one normal. The vast majority of the results were within normal limits, and the ones that were outside of limits were one-offs. So we decided to proceed further with VVOR, so visually enhanced VOR. Again, this is another test of cerebellar function. If you start to see gains that peak above 1, that is a great indication that your cerebellum is not functioning properly to smooth out or restrict some of your movements. Now, he has a 0.91. That is a normal result. So Even with the microsaccades, we're not necessarily thinking cerebellar, but it is still something to consider. We wanted to double check this function of the cerebellum, so we will do the visual fixation test to see if giving someone a visual target during the SHA will help reduce that eye movement. And in his case, it does. So his gain goes down from a 1, in theory, to a 0.15. So he has an 85% gain reduction. That is within normal limits. Again, if you had cerebellar issues, you would not be able to drop your gain that low with your eyes. Your eyes would continue to move despite the fixation target. So because we did those 2 tests and we kind of had a feeling that we were going to do them, that's why we didn't bother to clean up the data with the fixation on the calorics. This is a little bit more sensitive to what we were looking for anyways. Here is a real kicker. SVV. So you could see the data right here. This is what the patient thought vertical looked like. 2.5 is your roll angle limit. So anything that is plus or minus 2.5, if you exceed that, that is an abnormal result. His mean was negative 5.73. So he is, more than double out of a normal range to the left. Also, his variance is a 5.775. That is very wide. So typically, if you have a peripheral issue, you're more likely to have the SVV lean towards the lesion side, but that variance is going to not be that big. When you have more central issues, you can still have the skew deviation towards the lesion side, but that variance will widen. So at this point, we were starting to really think that something was central. I'm going to go over all the abnormal results that we found. So saccadic intrusions on 0.7 hertz smooth pursuit, absent CVIMPs bilaterally, reduced amplitude on a left V hit, leftward tilt and a very wide variance on subjective visual vertical, and microsaccades noted throughout the testing. So, with that being said, on our report, we sort of gave the other providers, the other people who are in the other professions who are giving this guy various assessments, our reasoning for why we decided it was central vestibular dysfunction on the left vestibulo-ocular pathway. We had normal peripheral findings during calorics and no covert or overt saccades on V-hit, which even with compensated lesions, you can find covert and overt V-hit saccades if they're on the periphery. But he had good function there, had good function with calorics. Those are most sensitive to peripheral vestibulopathy, but we got normal results there. So the microsaccades, the wide SVV variance, the saccadic intrusions on smooth pursuit, those all pointed to central issues. So what referrals did we give him? We sent him off to neurology, and we also said that you could also go to neuro-ophthalmology because, again, we think this is an eye issue. He was already working with occupational therapy. We told him to continue on that treatment to just better improve his balance and to compensate for any other sort of secondary balance issues that are contributing. And then lastly, because we're audiologists, new audiometric evaluation and possible hearing aid consultation, especially because he has that asymmetry. So thank you for listening to me at 2x speed. Yes, I called you out because I know you all too well. Deal with it.